now you get to hospital, and the healthcare provider, you have to decide, are you going to panic now or not panic? Okay. So hopefully after this presentation, your answer will be, I will not panic. Okay. But the patient comes in and he's panicking. So we've got let's say a 25-year-old guy. He comes in, he's bitten by a snake 20 minutes before. He is scared, he is sweating, he is panicking. He says, doctor, please help me. What is your approach going to be? And then, as you're starting to assess him, he says, I've got a picture of the snake. Somehow the picture doesn't want to come. There we go. All right. So he brings the picture. He says, Doc, it was a black mamba. So what would you do with this patient? Anyone? What would you do if you're the doctor now? Okay, so I would discharge this patient immediately, because that's not a black mamba. That's a mole snake, non-venomous. Okay, so there's no concern for this patient. So it brings us to the question of identification of snakes. Do you identify the snakes to treat a snake bite? Not necessarily, no. Does it help to identify? Yes, it can help. Okay. The problem comes in with the identification process. Who identifies the snake? So, do patients know snakes? Some of them confidently will tell you, I know snakes. I've had many of those. If they do say that, then give them, sorry, this pointer is not working nicely. Give them this image and quiz them. Tell them to choose which ones are going to cause them harm and which ones won't. So you've got 10 snakes there, 1 to 10. Which snakes do you think is going to cause trouble there? Okay. You can then even make it quicker, because the patient is suddenly going to be very confused, or he's going to point out to the wrong one. So you can say, okay, 3 of them are going to cause you potentially serious harm. 3 of them can kill you. Which 3? Yes, what? Top mid. Yeah, okay. Any others? Okay. So the point of it is, if you're not going to be able to identify it, what makes you think the patient will? Okay. So the top 3 are the ones that's going to cause you harm. The rest are completely harmless. Okay. Okay, another quick quiz. Okay, snakes are quite fast, so you don't have a lot of time. Okay. So, what was that? Oh. Snakes, imagine, and now you're bitten by the snake as well. So now you're stressing. Okay, so can you name the 3 snakes? No. Okay, so the patient is also not going to be able to identify it. Oh. Sorry, just want to go back. I don't know what's happening. Okay, so they vary color in the different areas as well. So I don't trust patients to identify snakes. I don't think you should either. This is why we use the syndromic approach. So instead of relying just on the snake identification, we look at the symptoms, because that's going to help us decide should we give antivenom or not. And the antivenom covers many of the snakes, the same antivenom. So you don't need to know the individual snake necessarily. There's a few caveats to that, but we'll talk about that. You can also often figure out what snake it was just by looking at the symptoms. So these are the main syndromes that we're going to deal with. So the painful progressive swelling syndrome, the bleeding syndrome, and progressive weakness syndrome. And then you also get a mixture of these. So progressive weakness and swelling, that is, like Tia said, that's the snouted cobra. Can cause a very confusing picture and can lead to misdiagnosis if you don't monitor the patient. And then you get swelling together with bleeding. We're going to deal with that. And then quite a lot of times mild to moderate swelling. Luckily, this is often the presentation. Easy to treat because you don't have to do much. Okay, just be able to identify it correctly. All right, so let's assess this patient first. What do you see? Swelling. Okay. You can see the hand, the position of the hand. That's not a natural position of the hand. Hand is usually either mostly closed or completely flat. Nobody sits like that with the hand. It's because of the swelling. Okay, what else do you see? Blistering, very good. And with the blistering underneath it. Yeah. And look at the color. Can you see there? It's a dark patch there. Okay. So this is your painful progressive swelling syndrome, and this is the things that you look out for when you try and diagnose this. It's not very difficult to see, but where it becomes difficult is if you have to decide, is this mild to moderate swelling or is it painful progressive swelling? Okay. Snake responsible, it's your Mozambique spitting cobra. So just watch out for them. The thing with the Mozambique spitting cobra, which you can get from your history, is also ask them when were you bitten or what was the circumstances. If the patient was asleep in their bed and they said the snake bit them while they were asleep, then almost 99% chance of it being a Mozambique spitting cobra. So you can figure out from your history what it was without knowing what snake it was, or that nobody identified the snake. So yeah, even the snake people don't like this snake. Okay, and this is what the result is of a Mozambique spitting cobra bite. They get subcutaneous necrosis and swelling. So it looks like compartment syndrome, but it's not in the muscle, it's above the level of the muscle. So your blood supply is not at risk, your nerves are not at risk, but you do get this necrosis. And then you get what they call skip lesions. So you can see it's two separate lesions there at the top. And this happens just with Mozambique spitting cobra bites. And then they get this awful necrosis that needs debridement, can get septic. So it's really an unpleasant bite to have. So you won't necessarily die, but you'll live with a lifelong morbidity because of this snake bite. Our next syndrome, so we're dealing with the swellings all first. So painful progressive swelling together with bleeding. So this you usually pick up on your blood results, but you can see some symptoms of it. It's not like the pure hemotoxic snake bite that bleeds out of every orifice, but you can see a little bit of blood at the bite site. And then on your blood results, you'll see low platelets and a moderately raised INR. So which snake is the responsible one for this? Correct. Puff adder. Okay, so there's a few of them there. So if you see a bite with significant swelling, you do your bloods and you see the platelets are low, it's a puff adder. You can, again, syndromically, you can identify the snake. So what you generally get is larger blisters than with the Mozambique spitting cobra. So it's large blisters, it's significant swelling, it's really an unpleasant bite, and then you can see the bleeding at the bite site. Okay, so it already gives you clues about what's going on here. And then this poor guy that took the bite, he lost his thumb as a result of it. So this snake bite in certain areas of the body can lead to amputations of digits and things. It's a nasty bite. Antivenom is very effective for it though. Okay, so what do you see here? Can see swelling, yeah? Okay. compared to the others, yeah, it's mild. There's no blistering, there's no discoloration. You can see it's swollen, but it's, it's halfway up the arm. It's not that bad. So this is generally what your mild to moderate swelling look like. And these patients you don't need to treat. You can conservatively treat them. They're going to be fine. Elevate it, wait, give it time. It's going to come down. They'll be fine. So how do you differentiate painful progressive swelling versus mild to moderate swelling? So if you treat a lot of snake bites, you get used to it and you can kind of identify it. But if you don't, there is a bit of a guideline. This is not hard and fast rules. It's a guide. So to give you an idea, so you can see if it crosses 2 joints within 6 hours, I would say, look, if someone comes to me in 8 hours, it's crossing 2 joints and it's still progressing, I would still say it's painful progressive swelling. So like I said, this is a guide to help you a bit. If the swelling keeps progressing more than 5 centimeters an hour, then you're probably sitting with a significant swelling. So, and then when you get the discoloration, that's a sign there's going to be necrosis. So that's painful progressive swelling. Generally, the snakes responsible is the stiletto snake and the night adder. So do you know what's unique about the stiletto snake? So they mentioned it earlier, but say again? Can bite many times. Okay. Only snake also that you can't safely handle. So the snake handlers tear on them, they grab the snakes by the neck, look very cowboy-like. If you do that with a stiletto, you will get bitten. Reason is they've got side fangs, so they just do this with their head and they jab you from behind. Okay. It's a small snake, 40 to 60 centimeters, and because they're small, people think they can pick it up. All right, so pick it up, get jabbed, pick it up again, get jabbed again, and that's where you end up. So be careful of them, because even though they cause mild to moderate swelling, if you get bitten on a small surface area, you can get a lot of damage because the venom is now concentrated into a small area. It's not like on a limb. So you can get, this is from a stiletto snake bite. Again, conservative management, and this patient was fine. So don't go cutting off this thumb. All right, so be hesitant with your knife. Like take time. You don't need to go cut things. Okay. Just something about compartment syndrome. So compartment syndrome is extremely rare. If you diagnose this is the treatment. So you can imagine what the rest of this patient's life looks like. Okay. So you don't want to just go making this diagnosis. It's extremely rare in snake bites, and the only way to actually diagnose it is to measure the compartment pressures with a striker needle. So in the absence of that, you can't really make that diagnosis. What you can do, though, if you have an ultrasound, put it on and you look at the muscle compartment. What you generally see is the muscle compartment looks the same one side to the other side, but the subcutaneous area is where the swelling is. So then you know it's pseudo-compartment syndrome. It's not your true compartment syndrome. So please don't go, I've never diagnosed compartment syndrome in snake bites. I've treated hundreds and hundreds of snake bites. So don't go diagnose compartment syndrome. That's old medicine. Okay, next up, bleeding. I made this dramatic for a reason. Okay. Okay, I'll stop it because it's a bit disconcerting. This syndrome, you need to be able to differentiate from the others. Why? Because your treatment is going to be different. Okay. It's got its own treatment. All right. So as a doctor, as a paramedic, as a nurse, this is critical. You need to be able to diagnose a pure hemotoxic or bleeding syndrome. All right, because your treatment differs. Features is it takes time, which is good and bad. Good because you've got time to diagnose it. Bad because when they present 2-3 hours after a bite, they're asymptomatic and you think, it's a dry bite. Send them home. Come back a day later dead. All right. So the reason for this is a venom-induced consumption coagulopathy, right? A lot of big words. What it basically does, I'm going to show you on the pictures just now. the blood starts to form little microclots, shoots off everywhere, okay? This takes time, so it shoots off and then it gets broken down. Shoots off, gets broken down. So over time, all your clotting factors get used up, all your platelets get used up, and that's when you start to bleed, okay? This is why it can take hours. So they find 4 hours after a bite. By 16 hours, they're bleeding out of every orifice, okay? Also, without antivenom, you won't save the patient. You can pour as much blood products as you want into this patient, you won't stop the bleeding. You can compression bandage, it'll bleed through it. The only way to save them is antivenom. So this is why I'm taking time, this is crucial to identify. You don't see many of these bites, but if you see them, this is a patient that will die unless you get antivenom into them. So please be able to recognize this. We're going to talk about the 20-minute whole blood clotting test just now. Okay, which snake is responsible? Boomslang, yeah, sharp guys. All right, that one that was quick and nobody could identify in the beginning, boomslang. Okay. So picture to show you what I was talking about. Can you see the black tips of this guy's fingers? All right, that's those microclots that went to the ends of his fingers. So it formed, basically started forming necrosis. And then once the clots were all, clotting factors were all used up, then he started bleeding. This patient unfortunately passed away, so he died about 6 hours after the bite, which is actually very fast for a boomslang. Usually they take longer. It can take up to 24 hours to 48 hours even to develop this. Okay, so easy way to diagnose it. You don't need a lab. Take blood, 2 or 3 mils, put it in a syringe, not in a syringe, in a tube, a clear tube without any precipitants or anything. Leave it for 20 minutes. After 20 minutes, you take it, turn it around. If the blood is still flowing, you have to be worried about a bleeding syndrome. Okay, so very easy bedside test, anybody can do it. If you can take blood, you can do it. Okay, next syndrome is progressive weakness. So Tia has already spoken a lot about this. What you need to remember is S's and P's. You can see there the list of symptoms. And it's true what everybody said. Patient looks drunk. Okay, it's the easiest way to explain it. So we've had an unfortunate case in one of the hospitals I worked at. So patient was bitten, came in saying he was bitten. And it was like the Ihu and the others said, the patient basically appeared drunk. So a community service doctor saw the patient, and she noted saying, patient complains bitten by a snake, no swelling, patient looks drunk. And she's so used to seeing cytotoxic bites, just 90% is cytotoxic, so she was just like, it's a drunk guy that says he was bitten by a snake. Her plan was admit him to the ward. So he was admitted to the ward. The next day on round, they found him dead. So she missed the neurotoxicity. It was there in front of her. She saw it. She saw the neurotoxicity. She said, he looks drunk. So she knew it. She just didn't put 2 and 2 together. So, and that's the problem with snake bites, especially in a high-frequency area. You see so many cytotoxic bites, you get so used to it, you lose respect for snake bites. And then this happens. Don't make similar mistakes. Okay. And no awards for knowing which snake causes this. It's your black mamba. Okay. So we've got a little bit of time, so quickly tell you a story about this black mamba. So there where I am, there's no one catching snakes. Any good snake is a dead snake there. So I have to catch the snakes. So this black mamba was in one of our storage areas. So I went in to get it. It was after the last box that I packed out. There it was, and I caught it, very proud of myself, walk out with it, get it to a container, and as I try and put it in the container, I realize the container is too small. And I've already let go of the one side. I only have the neck left, and the whole body is there, and it's pushing against me. I'm realizing I'm losing control of this snake now. So I basically let go, throw the snake, step back, my wife is behind me. The snake goes in between my legs, through in front of my wife, and kind of makes a beeline for the fence. So then I catch it again and get a bigger container and put it in. Reason I'm telling the story is that snake could have bitten me, my wife, multiple times. If it was this psycho snake that everybody says, this snake that just attacks everybody, I would have probably not been here today. So it's a snake that's really shy. It wants to get away. It doesn't want to attack. It bites when it's threatened. So just advocating for snakes a bit. Okay, I hope the audio to this is going to work. But this is a patient I saw bitten by a black mamba. She was close to hospital. She got to hospital quite quickly. And this was about half an hour after she was bitten. Okay, I can maybe play the... You couldn't hear, right? Shall I just maybe put the mic in front of it and try again? Okay. Sorry. Let's do it one more time, seeing as I figured out where the speakers are. Okay. Okay. So could you hear the way she spoke? Struggled to say her name, slurry speech, can't open her eyes. She was at one point saying, doctor, can you just move my head from one side to the other? That's called broken neck syndrome, where they lose control of their muscles. So all of this, the first thing you see, it starts centrally. All right, so any neurotoxic envenomation, just talk to the patient, look at their face, then you're going to see it. All right. So she was quite quickly in a lot of trouble. Then Tia also showed this, but look at the calf muscles. Can you see the fasciculations? Okay. That's typical of black mamba bite. You're not going to see that with the snouted cobra bite. Okay. So if you see that, then you know it's a mamba bite. It's basically as a result of a protein called fasciculins in the venom, and it does this. Very unique to mamba bites. Snouted cobra bite and wrinkles, this gives you the mixed toxicity picture. This is what Tia spoke about. You'll see a patient, they present with some swelling, and in a few hours later, they start to get these central neurotoxicity signs. Okay, they'll also get ptosis, they'll also get this slurry speech. Often they vomit a lot, so just be on the lookout for that. But this is the critical part about monitoring your patient. You can't just say, cytotoxic, fine, go to the ward. Okay. A few hours later, you might have a patient in big trouble. So keep monitoring your patients is basically one of the key messages, especially with these mixed syndromes. Okay. Shall we take a quick 1-minute break where we all stand up? We're going to get into the medical management of all of this just now. So, tell people snakes are friends, not foe. Okay, guys, we're going to restart. Okay, guys, so we're going to deal with the nitty-gritty of how to manage your snakebite when they get to the ED. So we dealt with the syndromes, recognizing the syndromes. Now the practicality of how to navigate a snakebite that's safe for you and your patient in the emergency department. So first things first, when your patient comes in with a snakebite, what do you do practically? What's the first things you should do? And you can greet your patient. That's be courteous. Okay. As with any other patient, get your vital signs. And then you can already recognize danger signs. So what do I mean by danger signs? Neurotoxicity. Any neurotoxicity is a danger sign. You can see that when the patient walks in, just look in their eyes. If you see they are bleeding, that's a danger sign. And no prizes for the next one. If you see a painful progressive swelling syndrome. Okay, pretty easy snake bites. You have to remember 3 things. Okay, a little bit more, but this patient, so he was not at risk of losing his life, but his story is he walked in a field and got bitten, went to a GP who said, "You're not bitten, you've got cellulitis," was discharged home with antibiotics. 3 days later, this was him. So his life was not at risk, but he suffered the morbidity that we are concerned about with snakebite. It's not just about saving lives, saving limbs as well. So this guy's whole life fell apart because of this. So he lost his job, wife left him, he sit with a chronic edematous leg, he can't do much. It's a very sad tale, and this is what we're trying to prevent. So your danger signs are your life-threatening signs, but also things that could cause lifelong morbidity. Okay, we spoke about airway and ventilation, so I trust that you understand how important that is, because your neurotoxic snake bites, you can save a life without antivenom, just if you can do airway, vent, and breathing management. So remember, ATLS principle still applies. Look after your airway, assess the breathing, sort it out if there's problems. If you've got neurotoxic signs, you're going to have to think very carefully if you don't take over the airway at some point. Okay. If you have antivenom right there and then, you can prevent it, yes, but you need to know what you're doing. Otherwise, if you want to be safe, if you see neurotoxicity, then just take over the airway. Make sure they can breathe. That's how you save your patient. Okay. So for me, first-line treatment for progressive weakness is airway and ventilation. Okay. That's your first-line treatment, your first concern. If you sort that out, you've got many hours to give the antivenom. Okay. So you can source it from a different place even. Okay. In presentation, so patients come with snakes sometimes. So this Gogo obviously won the battle against the Mozambique spitting cobra, but her friend was bitten. But what are the things you want to know from the history? What's the one most important thing in a snake bite when it comes to history? For me, the most important thing, like all the other things I can live without. Yes, beautiful. Time. Because time is what determines if this is a significant envenomation or not. how quickly the symptoms progress. If a patient comes in, says he was bitten 6 hours ago, and he's got swelling that's sitting basically up here to the leg, up just above the knee, I'm worried about that patient. If the swelling is above the knee, but he was bitten 48 hours ago, then I'm not that concerned. Okay, so timing makes a big difference. If it was bitten an hour ago and the swelling is up to the knee, that's a significant envenomation. If that's the case 16 hours from now, it's not such a big deal. Okay, so timing is very important. And then circumstances, like I said, Mozambique spitting cobra, if he was bitten at night, if he was sleeping, it's a Mozambique spitting cobra. All right. So, and then first aid. You have to ask, did the patient apply any first aid? Because a lot of what you see, the syndrome, might actually be because of the first aid applied and not the venom. Okay. Snake descriptions, IDs, like I said, like we went through, I don't put a lot of faith in patients' descriptions of snakes because the snake also grows the more time goes on. So initially it was a 1 meter snake, 6 hours later it was a 4.5 meter king cobra, and I've recently had someone that went for a walk in the Western Cape, and then they posted on Facebook that they saw this little guy and they put a picture of a snake, and they said it was about 1.5 meters. So the snake was a stiletto snake, which does not occur in the Western Cape, and their max length is around 60 centimeters. So that tells you all you need to know about people's descriptions of snakes. If you have, especially with the guys active here looking after snakes, the guys working here cleaning cages, find out if they work with snakes, have they been bitten before? Because what you can get is a guy that's sensitized to snake venom. So even a little scratch, which in a normal person wouldn't cause anything, can cause anaphylactic shock for someone that's sensitized. So you guys be careful around your snakes, eh? And then find out other medical history. Are they in medication? If someone comes in bitten by a snake and he's on warfarin and his INR is 3, I'm not worried about that. If it's a patient that's never been on any medication, their INR is 3 with a snake bite, then I'm worried. Okay, so just find out those little details. Okay, let's assess this bite. So this patient was bitten on the foot. You can see the swelling, you can see the dark patches. What do you think about this bite? Painful progressive swelling, it's got discoloration, got progressive. So this patient was bitten by a stiletto snake. Can you see the indentation mark just under the knee there? Tourniquet was applied. He went to a traditional healer who put black muti on there. So all of the symptoms here are basically because of the first aid. So we admitted, we elevated the leg. The next morning the patient went home, no symptoms. So find out, did they first go to a traditional healer? Did they tie a tourniquet? Just keep an open mind. Okay, let's assess this patient. So he was bitten a few hours before, comes in holding his hand. All right, what do you guys think? Yeah, swelling. There's a bit of discoloration. There's a bit of bleeding. Can you see the dried blood there? Okay, it's a little bit of blistering. It's a question whether there's a tourniquet that was applied. In this patient, there wasn't actually a tourniquet applied. Okay, but the swelling is only up to a year. Okay, so what would you do with this patient? This is where snake bites become tricky.
She was bitten when?
Like a few hours, like 4 or 5 hours ago. All right. I put this case on purposefully. There we go. This is what we did. So because it's a very small area of necrosis, you're not going to change that with antivenom. It's already there. The swelling is not significant. It's there, but it doesn't really fit with painful progressive swelling. So we admitted and observed this patient, and after a few days went home like almost no necrosis, and he was fine. So what do we do on assessment? You do your vital signs, your danger signs. You recognize the syndrome, which is what we did here. We're like, it's a question. Is it painful progressive swelling? Is it mild to moderate swelling? It can still change. You can change your mind. So what you need to do is you observe. And by that, what do we mean with observing? Is you're going to check hourly for the swelling. You're going to mark it, check it hourly. Because 5 hours from now, you might decide this is actually painful progressive swelling. And you might change your mind and give antivenom. So observe these patients. And then, look, there's a bit of blood that leaked there. So you want to rule out a bleeding syndrome or a mixed syndrome. Easiest way, full blood count, INR, 20-minute whole blood clotting test. All of that is focused at ruling out bleeding syndrome. Okay. So for me, those are your standardized tests. U&E, your renal function, I don't put a lot of emphasis on that in the beginning. If you have a complicated case, yes, then you start to worry about it. But almost all of these patients, U&Es will be fine unless they have a pre-existing medical condition. All right. So, but you can do it as a baseline if you're very thorough. And then all of them, we have IV access for support. You don't know when things might change, so get them IV access. And then mark the swelling like we said. Okay, so that's my ED initial assessment, what I do. Next up, antivenom. Okay, so I think there's a lot of other talks going to happen about antivenom. This is the SAVP product, the one that is basically currently not properly being produced. So there's a massive shortage. Okay, this is a huge problem everywhere. And it is why you guys in Eswatini decided to discard it for good and change it to this product. Okay. So antivenom is very effective if given for the correct reasons. The SAVP product especially can be quite dangerous because you can get anaphylaxis and then you sit with a whole nother problem that you've made for yourself. So you don't take the decision to give antivenom lightly. Okay. Just a reminder about how antivenom is made and why the products are dangerous. So they inject horses over a period of 9 to 12 months with snake venom with the different snakes. Okay. The horse builds up antibodies to these venoms, and then the serum gets extracted, purified, and you're injecting horse serum into humans. This is why it's a foreign protein, so you get anaphylactic allergic reactions to it. Okay. So I know with the ICP product, like you seem to have very little side effects, but still, it's still a foreign protein, so still respect it. Okay, what snakes are covered? So the ICP product in Eswatini is black mamba, snouted cobra, Mozambique spitting cobra, wrinkles, and a puff adder. I think I got that right. Those are your main snakes. These are your dangerous snakes, your life-threatening snakes. It covers all of those. For the SAVP, you use the thing 4 cobras, 3 mambas, 2 adders, 1 wrinkles. So the mambas are black, green, Jameson. The cobras are your Cape cobra, your forest cobra, Mozambique spitting cobra, and snouted cobra. Puff adders, gaboon, or adders are puff adder, gaboon adder, and then your wrinkles. The crucial thing here is the monovalent antivenom. Bleeding syndrome, remember the big splash of blood, gets its own antivenom. So bleeding syndrome is a boomslang bite. You don't get swelling with it, you just get the bleeding. So if you see that, you have to get a hold of monovalent antivenom. Only SAVP produces this. I don't know if there's plans for Costa Rica to jump in here, but this is the only way you're going to save your patients. So again, differentiate your bleeding syndrome from all your other syndromes because it gets a different antivenom. The others, whether it's a snouted cobra, black mamba, puff adder, you're going to go give all the same antivenom. Okay, that's why again identification is not that crucial. Yo. It's black mamba, snouted cobra, wrinkles, puff adder. Which one am I missing? And Mozambique spitting cobra. Yeah. Okay. Question of how much to give. So The numbers there are the ICP recommended dosages. The ones in brackets is the SAVP. So you see you have to give quite a few vials for the polyvalent because of the nature of how it's made. It covers many snakes, not just one snake. So the monovalent is made with just the boomslang venom. So there you only have to give 1 or 2 vials. Okay, so that explains why you have to give more with the polyvalent. Okay, so who do we give it to? When do we give it? Any danger signs that this patient, their life is at risk, or they're at risk of significant morbidity. All right, so all your main syndromes. Then look at your blood results. If your platelets are low, you've got a puff adder bite most likely together with the swelling, then give the antivenom for that. Okay, and then the boomslang. If you've got a boomslang bite and it's confirmed, like the snake was identified, you don't wait for toxicity. So this is the advice from the experts. Because once the toxicity sets in, once the bleeding starts, it's so difficult to stop, and it's a horrible death. They bleed everywhere, they bleed intracranially, intra-abdominally, everywhere. So to try and reverse that process is so difficult. So if you've got a boomslang bite that's confirmed, just give the antivenom even before anything starts. Okay, so that's the general advice for that. Okay, now how to give. Preparation is key. Okay, so any of you treated anaphylaxis before? Scary? Very scary. Okay, so a patient literally collapses in front of you, the blood pressure drops into the boots. Like, if you can avoid it, you want to avoid it. And there is a way to avoid it. So they did some studies. They found if you give adrenaline subcutaneously before antivenom, then you reduce the incidence of anaphylaxis with up to 30%. Okay, which is well worth doing. Very important, it's different from treating anaphylaxis. So you can see subcutaneous. For treatment, how do you give it? Intramuscular, right. Why do you think subcut as a pre-treatment instead of IM? Yes, so the absorption is slower, but what you get is a longer period where you get covered. If you give it IM, works for about 10 minutes, halfway through your antivenom, you lose your adrenaline benefit. So you give it like 5 to 10 minutes before you start, and then you cover it for up to 45 minutes. Okay. You don't give hydrocortisone and promethazine as a pre-med. So interestingly enough, the study found that if you give those things with the adrenaline, you lose the benefit of the adrenaline. I don't understand the pharmacodynamics of that, but that's what they found. So don't give it as a pre-treatment. If you get anaphylaxis, sure, then hit them with your hydrocort, your promethazine, and everything else. Okay, so that's clear. And then once you give it, so the most important thing for me is monitoring. So practically what I do is I put the patient on cardiac monitor, SATS monitor, and I put the BP cycle on 3-minute cycles. If there's any BP drop, you give your adrenaline IM and see if you can get it up. Okay. If you can't get it up, stop your antivenom. All right, and first sort out the blood pressure. In South Africa, we use the saline method where you inject it into saline, let it run over 30 minutes. I think here, I don't know with the ICP, do you give the push? Yeah. So the push, and so far, from what I've heard from Tia, no real anaphylaxis, which is amazing. The cool thing about doing the push dose is it means you're staying with the patient. You can't walk away. So if you administer antivenom, whatever fashion you do it, do not walk away from the patient. Okay. You can't treat anaphylaxis if you're in the next room. It's too late. Okay. So be with your patient. I monitor the patient for an hour after the antivenom was given. I stay with the patient. Okay. And only then you can get them to a eye care facility. Children, what dosage do we give to children? Same. Who says same? Who says different? Same? Different? Different? No? Why? Why same or why different? Right. Okay. So to answer the question, you just have to ask yourself, are snakes anesthetists? Do they adjust the dose that they give when they bite? Because it's a small child, I shame, will give half dose. No, they give whatever they decide to give. So you have to neutralize the amount of venom, not the body, the package that the venom contain or is contained in. All right, so be clear about that. Okay, if your patient did come with a tourniquet, there's a special way of treating that. So generally the tourniquet is for neurotoxic snake bites, black mamba. Usually you'll see some symptoms because some of the venom would have gotten through, so you'll see a little bit of the neurotoxicity. Do not remove that tourniquet. What you get is a venom rush. The patient will collapse right in front of you if you do that. Okay, so we do a stage release. You apply a blood pressure cuff above the level of the tourniquet, okay, and then you blow it up to 10 millimeters mercury above the systolic blood pressure, okay, to basically compress the vessels to stop everything from coming through. Then you start your antivenom, and you can release their man-made tourniquet while you give the antivenom. Once your antivenom is done, you wait for 15 minutes. Then you do a stage release. What that means is every 3 to 5 minutes, you come down with your BP cuff 10 millimeters mercury and you watch for symptoms. If there's no symptoms, you keep doing that until it's completely released. If you see symptoms recur, blow up the cuff again and wait. You can also decide, should I give more antivenom? Okay. And that's how you do it with a neurotoxic bite with a tourniquet. Clear? Everybody can do it? Cool. Okay. Once you're done with your antivenom, now you can't just walk away. Everything is fine. Everything is not yet fine. You hope it's fine, but it might not be. You have to monitor this patient. You may need to give antivenom again even. So you need to have a place where people have eyes on it, ideally a high care facility, where they can be on a continuous SATS monitor. You can do your blood pressure and vitals every 30 minutes. You check the swelling hourly. Okay. A lot of places don't have that. Where I work currently, we don't have that. We've got too many snake bites, too few beds in eye care. We can't do it. We keep them in our ED, so we keep them in front of us, so we look at them the whole time. Okay. If you've got a serious envenomation, if you had to give antivenom, there's no question. They go to eye care. There's no ifs, ands, or buts. It's about the patients that mild to moderate symptoms. It might change, so you need to be able to monitor them. Okay. All right. Finally, just to reiterate, you can beat neurotoxicity just with ventilation. Okay. For your non-spitting cobras, this is your snouted cobra. Remember, mixed syndrome, they can give swelling and they can give neurotoxicity. If you don't have antivenom, you can give neostigmine. Okay. Works at the acetylcholine receptor at the neuromuscular junction, and it can basically reverse the toxicity for short periods of time. So you can win yourself time to get to antivenom with neostigmine, prevent them from going into respiratory arrest. So keep that in the back of your mind if you have access to that. Specifically for snouted cobra, it does not work for black mamba venom. We can talk about that afterwards. There's a whole complex reason why that's the case, but specifically snouted cobra. For painful progressive swelling or any other swelling, you elevate it above the level of the heart. Whatever limb is bitten, lift it in either, some people do a drip stand. Pillows sometimes people do, but I find they generally fall off the pillows. So if you can fashion something, just get the limb above the level of the heart. That reduces the swelling. Okay. Support them with IV fluid. If there's necrosis, don't rush to theatre. You've got time. Generally, we wait 5 to 7 days. Prof. Tim will talk about that before we do debridements. Antibiotics is not indicated in snake bites. Okay, it's been proven to not be of any benefit. If you have, in 2 or 3 days' time, a cytotoxic bite that's developing an abscess or infection, sure, then give you antibiotics. But it's not indicated in the beginning. Most, like by far the majority of snake bites doesn't have infective complications. Okay. And then, just as a last slide, my patient. Tell me again, what's your name, ma'am?
My name is Pindugushla.
Okay, good, ma'am. So this was 2 hours later after I've given the antivenom. So antivenom is awful, but it's also great. So if I think I've got hope with the ICP, if they continue to not get anaphylaxis, then it's a fantastic drug. So yeah, give your patients antivenom. It makes a world of difference. And then if you forget pretty much everything I said, you've got your flipper charts. So most of what I said is in there, probably more than what I've said. So yeah. Okay, that's it for me. Thank you very much. Sure. Yes, yes. Yeah.
Kudos to that. But for me, who's working in a semi-rural township where I don't see the complaints, and at one point when I went to check my antivenom, it was expired. So now, the same patient that survived just symptomatic management, like if they come with
Progressive weakness. Yeah.
Yeah.
So, yeah, it's interesting. There's quite a lot, not a lot, but there's quite a few articles and literature written about specific cases. So what generally happens with the progressive weakness, if you don't have antivenom and you try and ventilate them out, they're often, the standard they say is that you ventilate them for up to a week. And then there's been cases where it's been more than a week where you had to ventilate them out, but afterwards they were fine. No major problems. There's one or two cases where there's a patient that's got mild facial paralysis. So there's a few of those, but the majority of them, if you ventilate them out, they walk away without any permanent symptoms, unless they've had complications from the ventilation itself. Yeah, but if you give antivenom, then generally the ventilation is 1 or 2 days, and they're fine. So you reduce the effort and intensity and money and everything by giving antivenom. Yeah.
Okay, maybe I can add to your answer as well. I heard that she mentioned expired antivenom, right? Some studies are actually showing that expired antivenom can still be very effective even up to 25 to 30 years after date of expiry. So don't shy away from giving it. If that's the only thing you have, it will still be effective for your patients. And then my question was on the staggered release of tourniquet. How do you get a blood pressure cuff to maintain it a certain... It's only the manual ones?
Yeah, that's... Modernization isn't always progress. The manual cuff, yeah. Unfortunately, you can't get the electronic one to do that. Yeah, but just on the antivenom question, there's actually a recent article that was a paper that was published on how effective antivenom stays even 20 years later. So yeah. Yeah. 3. Yeah. Sure. Mm. Yeah. Sure. Of antivenom. Sure. Yes. Yeah, sure. Yeah. 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 Mm-hmm. Yeah. Sure. Sure. I'll try and answer all of that. Just remind me if I miss out. So the first question is about antivenom repeated dosages and monitoring after the initial antivenom. So with a painful progressive swelling, I would monitor the swelling. If you see 2 hours later the swelling is going up, you still use the same guides. If it goes up more than 5 centimeters and then give the antivenom again. So generally, I would say from experience, 2 hours would be the time where I would decide. And then the repeat antivenom, I don't repeat the same dosages. I give two units, monitor response, another 2 units, monitor response. Yeah. With the regards to children, what was your question? Oh, the IV fluids. Yes, very good question. And yeah, that is something that is unique to children. You have to monitor the fluids. So there's formulas in resuscitation for children that I hope you know, with gastroenteritis and those types of things, what's maintenance fluid. So you have to try and stick to that. So in general, look, a 5-year-old child will tolerate a 200 ml bolus, like a 3-year-old will tolerate that. Once you have a neonate, there it becomes a problem. So there I would try and get specialist advice if you have, because I've had a few cases where it's a neonate that was bitten by Mozambique spitting cobra. And then you need to know what you're doing with fluids, but this is like very rare, I would say. So they phone a friend that works with these types of fluid management on a regular basis, because you have to tailor your fluids then, yeah. What was your final question there? Oh, the debridement, yeah. So with the necrosis that you get with Mozambique spitting cobra, that's subcutaneous, that's not pus, that's liquefaction of fat. So it's not infective process. It looks a lot like pus, I know, and all you want to do is hit them with all the antibiotics you have and stuff, but it's the liquefaction of the fat that just looks like pus. So it's a lot of times it's not pus. Saying that, it can be infective as well. So if your patient is spiking temperatures, then of course, yes, there's an infective process as part of it. But so the idea, and Prof. Tim will talk about this, but what we do with this whole necrosis is we wait for 5 days so it demarcates. Because what they found is if you go and debride on day 2, there's still an ongoing inflammatory process for the next 5 days. So you're going to debride, and then 2 days later, now you have to debride again. And in 3 days, now you have to debride again. So you've taken the patient 3 times to theater, which is already traumatic. So the advice is, well, skip all of that. Wait 5 days, it demarcates, you know exactly where to cut, and then do it once, and it's better. So that's the mindset behind it. Okay. Overdose. You cannot, there's no ceiling for antivenom. You give as much as needed. So this lady that I saw, the neurotoxic snakebite, the one that talked so nicely at the end, I ended up giving her 22 vials of antivenom. So we started off with 10, and I kept giving until she improved. So there's no ceiling dose for antivenom. If you're not getting anaphylaxis, keep going. Sure.
Just 2 questions though. For the Snakebite program, do you get intervention with the neurotoxicity? And the second one is, I had 2 cases that were given hydrocortisone for a snakebite. They were cytotoxic, progressive swelling, painful progressive swelling, and both of them had a picture of desaturating. Like a few days later, they started desaturating.
Yeah.
I don't know, but it was like sort of looking like pneumonia, and they started desaturating. They had to go to oxygen for a few days before they recovered. Do you have any experience with that?
I don't have any experience with that specifically. You worried that hydrocortisone could have played a role with. Yeah, I don't have any experience with hydrocortisone doing that specifically. I mean, the only thing I can think of is that hydrocortisone is an immune suppressor, so they're more susceptible for organisms in the hospital, I suppose. But that's the only thing I can come up from the top of my mind. I'm not aware. Sorry, what was your first question?
The other question was the hypersalivation
Oh yeah. So with the snouted cobra, yeah, you'll get hypersalivation, swallowing difficulties. The difference is fasciculations you get with mambas, not with snouted cobras, and then sweating you get very early on with mamba bites. You don't get that with snouted cobra bites. When you get sweating, it's usually related to them being in respiratory distress already, so it's a very late sign. But with mamba, it's specifically with the muscarinic receptors that the neurotoxin works and that causes the early sweating. So there's a few subtle differences. It's, I think, a bit more academic interest because all of them, if they show signs, you're going to give antivenom. So, yeah. Okay. Yeah.
Yeah, so you raised something quite interesting here on the cytotoxin. Maybe when we were talking about the Mozambican spitting blood, even if you could help us on the
Sure.
issues, you said at least wait for at least 5 days from time of bite, right?
Yeah.
So that you can see if it demarcates.
Yeah.
So that liquid-affected process that's happening, does it sometimes go away like the space? I'll give an example of where I think some of the patients we come across, we see it and we call in the surgeon.
Yeah.
And then when you open up and you see that pus
Spread.
it really spreads.
Yeah. Yeah.
And you do see healthy tissue.
Yeah.
Above it and all that. So if you leave it for those 5 days,
Mm.
there's a chance that all that space can actually close up. And
Yeah.
you won't have such big wounds.
I don't know that it would close up by waiting. I think so. The thing is the inflammatory process. You can't stop that unless you've given antivenom early. So that process is going to go on regardless. If you cut now, you can't stop that with cutting. So that's going to continue. My experience, because out in the district, I used to do the surgery for them as well. So I didn't find that waiting necessarily reduces it. So that spread happens, whatever you do, it happens. And where it's spread, you open up and you clean out, and then it heals. Yeah.
And then blistering.
What to do with blisters? Yeah. So I think there's different schools of thought about it. So, but I think if you've got large blisters, then de-roof it. So large blisters, generally, they cause a lot of pain and discomfort, and it's unpleasant, and it's going to rupture in any case. So just de-roof it. If you've got small blisters, leave it. So then you don't have to fiddle with it. But large blisters, I would just take off, because then you can start doing dressings on those. Yeah.
I wanted to explain the mechanism between
Mm.
if you give both, like you say, all right, so let's go back to a bit of physiology. So the promethazine is phenothiazine derivative, isn't it? Which acts on the as an antidopaminergic, anticholinergic, as well as an antihistamine. It's a direct antagonist on your mesolimbic dopamine receptors 1, as well as the adrenergic receptors. So promethazine is actually selective. It targets the alpha receptors. Then adrenaline is non-selective, goes for the alpha and the beta. So what you do if you give both, you are essentially limiting the adrenaline only to the beta receptors, which are mostly in heart stimulating, and removing the alpha receptor effects which you're trying to achieve, the vasopress. So in a way, when you give both, you are actively competing for the alpha receptors and reducing the potency of the adrenaline. So in a setup where you have promethazine only, you lose nothing by giving promethazine. In a setup where you have adrenaline, you lose nothing by giving your adrenaline only. The problem comes when you give both at the same time, like what the old guidelines used to say. So you would rather give one if you have of the two.
Thanks for that. Just on the studies that they did, they found that because they checked promethazine only as well, and it did not have any effects. Yeah, so I think the thing with adrenaline is it's a mast cell stabilizer as well, apart from, so that reduces the release of histamine. So, yeah.
One, two.
I don't know if I'm going to use this right. Good afternoon, ladies and gentlemen. My name is Dr. Bongi. I'm with my team. Can you please come through? I've got Hlengiwe, who's a nurse, and Chaza is a paramedic where I work. We work for the RES clinic down at Simunye, and we do tend to see quite a number of snake bites. But today we just thought that together we can remind each other, just teach each other, especially on a neurotoxic bite, which is life-threatening, on a rural clinic setup. So basically, if you do not have antivenom and you are in the outskirts of the country. So our presentation will look at the pathophysiology of the neurotoxic venom. We'll look at the clinical presentation. We'll brush through it again. Dr. Christoph has already talked about it. We'll look at the emergency medical support that you need to be giving at the clinic. And then we'll zoom in specifically for the respiratory support. And then we'll talk a bit on practical procedures on monitoring symptoms and transportation of the client. And then we will talk a little bit on the limited resources and the community involvement. And then at the end, we'll do a bit of a summary on the neurotoxic bites and on the outskirts before we conclude. So we will be doing a bit of role playing with my clients. Chaza, maybe if you can come a bit closer so that you can be in the center, come closer here. So Chaza will be our patient as we present. And Hlengiwe will be the nurse at the rural clinic. So let's start off with the pathophysiology. I won't go much into it. Dogotela here, you could hear that he is the expert of pathophysiology. So later on, if you have questions on the pathophysiology, I know who my panel member will be. But if you do remember that we have the neuromuscular junction where the nerve meets with the muscle for muscle contraction. So there will be, there's no pointer? There's no pointer. Okay, so there will be an axial potential coming down the nerve where there will be activation of acetylcholine, which will be released into the synaptic cleft, where the synaptic cleft, acetylcholine will be attaching to the receptors, the nicotinic receptors at the postsynaptic membrane, which will then cause muscle contraction. And then a neurotoxic bite will block muscle contraction in two ways, which is presynaptic on the nerve and postsynaptic. From the presynaptic, it will prevent the release of acetylcholine. Hence, then the cascade of events that are necessary will not happen. So we'll go into flaccid paralysis. And postsynaptic, that means the neurotoxins or the polypeptides that come from the neurotoxins, they will compete with acetylcholines on the neurotoxic, on the receptors, preventing it from attaching. Hence, even then, it will be preventing the cascade of events that will lead to muscle contraction. I hope that was clear. So the mamba bite is also responsible. Studies say that for the muscarinic receptors. If you remember, nicotinic receptors are for the skeletal muscles, and the muscarinic receptors are for the smooth muscles. That means your GIT can also affect the heart and also cause, so that's what will cause mostly the sweating, the diarrhea, the excessive salivation, because it affects the smooth muscles. Okay, moving on. The species that are responsible mostly in the country for a neurotoxic bite are these two. We do have the wrinkles. I won't go much into it because the wrinkles are mostly cytotoxic and mildly neurotoxic. But the ones that we have in the country, we do have in South Africa other species that cause the neurotoxic picture. But in the country, it's the mamba that we all know, and then the non-spitting cobra, which is the snouted cobra. And then the other cobras in South Africa is the Cape cobra, I think the forest cobra, if I'm not mistaken. We do not have a green mamba in Swaziland. Tia always goes crazy when you talk about this because Swaziland or Eswatini people know that there is a green mamba. You can't tell them anything about that. They just say, we don't care what you say, we have a green mamba in Swaziland. But we don't, as far as you know. Maybe we'll find it one day, but we don't have it currently. So clinical presentation, our patients, they are early symptoms, and they will come in a descending paralysis pattern. So basically the symptoms will start on the face, going down. So the early symptoms has to do with the paresthesia. The patient will come in complaining of a numbness around the mouth, and sometimes they'll be complaining of a metallic paste on the mouth, and then they will have blurred or double vision. They will have pupillary abnormalities, and most of the time for this bites you'll have dilated pupils. And then you will have ptosis, which is the weakness of your upper eyelids. We've seen many pictures in the previous presentations, and this means that the patient will not be able to open their eyes. They'll try to be opening their eyes, but they won't be able to. And then we'll talk about the facial muscle paralysis, going down to this ultra as it comes to the neck. They will complain of painful swallowing. They'll have dysphonia, maybe the voice will change. And then as it continues down to the neck muscles, they will have the weakness of the muscles where the patient is not able to hold up their head. So they'll be dropping up their head. And in the books, they'll call it a broken neck syndrome because they cannot raise their head up. So they'll be they'll be hanging their head. Then the muscle fasciculations, we've seen what muscle fasciculations are, and we know that they are associated with the mamba bite. They will have, as it progresses, cardiac arrhythmias. This is later on as it continues. And they will be increasingly anxious, sweaty, cyanosed as they get, as the symptoms progress to your accessory muscles, your breathing muscles, and then they will get to respiratory failure if finally the paralysis reaches your diaphragm, meaning the patient has lost all effort to be able to breathe. So they will get to cardiac arrest and respiratory failure, and finally death if there's still no support. I forgot to mention there that sometimes you must make a distinction for this kind of patients, because there will be an activation of the autonomous nervous system. So they'll come anxious. So that does not mean they're envenomated. They'll be anxious, they'll be hyperventilating, they'll be having chest pains. Sometimes they'll even come up vomiting. But that is because of the activation of the autonomous nervous system. And we did have a case at some point in time where a patient, actually the snake fell from a tree, went down his shirt, didn't bite him, went down his shirt, and it went down to the ground. The patient came into the clinic scared, palpitations, vomiting, but we had to monitor and specifically look for the neurotoxicity signs. So you must be on the lookout for that. Don't give antivenom unnecessarily. So for the emergency medical support, first of all, we look at the first aid that you do. So remember that you are in a rural clinic We have bare minimum, we have limited resources. So the first thing that you do is you will reassure the patient, and whilst you are taking history, then you do remove restrictive clothing, and as you do your vital signs, you remove any restrictive clothing, as Dr. Christoph has said. Then you examine the bite site, look for fang marks, look for local envenomation, if there is anything there. And then what I need to emphasize is that if you do not see fang marks, it does not mean that the patient was not bitten. So even if you do not see them, you still have to monitor the patient. So you have to immobilize the patient and splint the limb. For cytotoxic bite, we did hear Dr. Christoph talking about elevating the limb so that you reduce the swelling. But for neurotoxic bite, you do not elevate, you keep it at the level of the heart so that you prevent the fast progression of the neurotoxic. And then you have a tight, if you do have a tight crepe bandage, you can apply it over the site. Okay, apply the crepe bandage. This is for a neurotoxic bite from a mamba snake, specifically for a mamba, not for the others. If you do have and you are sure about that bite that is from a mamba, you can apply the crepe bandage over the bite site and as far up as you can on that limb. And then you keep the patient immobilized, and you splint the limb, and as my team has done. And then supportive management, you do your examinations. You have to know your examination from ABC. You check your airway. You check your breathing, if it's effective. You remember that you use your peak flow, if you have it, to assess how effective your breathing is. And then you have to do your circulations, where you do your blood pressure. You do your pulses. You check your capillary refills. You check, yeah, that's what you do for your circulation. So we are putting the blood pressure now, which is very important for circulation, to assess how effective the circulation is. So as you do your examinations and your monitors, you also have to put up an IV line. This is very important. If you do have it in the peripheral clinic, you put up that IV line and secure it. And in the meantime, you have to continue. You have to do your continuous monitoring. This because we know that in a neurotoxic bite, the clinical picture can deteriorate. So you do not just do your examination once. You have to continuously do it to check and see if your condition of your patient is not changing. So it is important, if you can see, for this kind of a patient, that you have your basic BLS skills. For every healthcare worker working in the peripheral hospital, it is important for you to have BLS medical skills. Because you can see for this patient, the key, the skill that you need from BLS here is rescue breathing because of respiratory failure. The main problem is respiratory failure, like we said. So adequate ventilation is the gold standard. So she's doing her blood glucose, which is also important to do all your saturations. She's doing all of those monitors. Then let's zoom in into the respiratory support. So the key for respiratory support is to achieve optimal oxygenation until the patient is handed over to the referral hospital or to the nearest center that has antivenom. Then, because we know that hypoxia will cause brain damage, will also cause cardiac arrhythmias if it is not attended to. So it's not just basically to ventilate the patient only. You must make sure that your ventilation is adequate. So place the patient in available monitors. So our patient is already on monitors. Then do put oxygen. If you do have, if by some miracle you have oxygen, you can use your face mask or the nasal prongs if you have them. So, and then suction if necessary. If there are any secretions, do your suctions so that you can improve your ventilation. So what we have at the clinic, I think the bare minimum that we have to have is your BVM, your bag valve mask ventilation. That is the one that you need to have. This is for progressing cases. So analgesia, the basic minimum that you can give is paracetamol. And opioids, sometimes you must know that it can complicate a neurotoxic bite. So try not to use opioids if you can. And then there is no role for steroids and antihistamine and NSAIDs in management of a snake bite. But we have heard from Dr. Christoph that you can use it when they start having an anaphylactic reaction. Then you can use your antihistamine steroids. But then NSAIDs, please don't, because then for a bleeding picture it might worsen it. So NSAIDs, your Brufens and your Voltarens, they are not advised for snake bite. Then the gold standard is early intubation and mechanical ventilation for this kind of patients. But we know that most of us, we do not have, I was confessing to Dr. earlier that for me, I'm not comfortable in doing endotracheal intubation because of I don't do it often, so that kind of a skill, you kind of lose it if you don't do it much. So it is a gold standard, but if you don't have it, it is key that you continue just doing your respiratory support. So practical procedures, we did say we need to have the bag valve mask ventilation, but what is the most important is that when the picture progresses and they get to lose consciousness, the most important thing that you need to do at that point in time is to protect your airways, because we know that the tongue falls back. So no matter how much you can bag, your ventilation will not be effective. So what you need to do is protect your airway. So what we can do with the limited resources that you have, if you do have an oropharyngeal airway, you can use it. How do you know? How do you know the right size? We measure it from the angle of the mandible to the center of the incisors. That's how you know the right size, because it's important to you. It's important for you to use the correct size of the oropharyngeal airway. Open your mouth and insert it upside down, or use a tongue depressor to insert it. And then the flanks must lie at the front of the teeth, and check the patency. It's very key that after you've inserted it, you need to check the patency of your airway. Then another airway that we don't have here, which goes to show, I tried several hospitals, no one has it. The NPA, the nasopharyngeal airway. If you do have it, it is quite nice. We don't have it. Look at the praises, look at me funny. We don't have it. We're at the peripheral clinics. But if you do have it, it's also a nice one. It's even better than the oropharyngeal for you to ventilate. So if you do have the nasopharyngeal airway, you can use it. You insert it in your nose down to your lungs. I think we will see it one of the presentations when they do assimilations. They will show us the nasopharyngeal. If you're interested, you will see it then. So it's the same thing. After you've inserted it, check the patency of your airways to make sure that you are ventilating right. Then another one is the laryngeal mask. We also don't have it, but you'll also see it in the other presentation. So the laryngeal mask is also good. You can use it. Also needs to be the right size, and then you also have insert it down to your airway, and then you insert it, supporting it with your index finger until you feel the tip of the mask at the end, at the upper end of the esophagus. Then you can inflate the cuff. So this one is another way that you can use to secure your airway. But these ones that we say here, they are temporary and they have got complications. You can look up the complications of them, but because we're in a clinic setup, rural setup, the nice thing we have heard that Lucommission is coming to meet you along the way. So you'll be using this and having the effective oxygenation and saving a life at the same time. So moving on, I won't go into the orotracheal intubation and the cricothyroidotomy. We talked about it earlier. It is beyond the scope of this presentation, but the endotracheal intubation is the gold standard for a patient who has reached respiratory failure. Then monitoring, I think this will be just a repeat. You have to make sure that your oximeter is fine. You do a respiratory rate, your heart rate, your pulse, your blood pressure. Check your level of consciousness. How do we check the level of consciousness? Who can offer me how do we, the two ways we can assess the level of consciousness? Anyone? How can you say, okay, now the patient is this way or the patient is deteriorating? What are the two tools that we can use in a rural clinic? It's the glaucoma scale. That's the first one. The second one is the AVPU. The AVPU is if they're responsive, if they're alert, if they're responsive to verbal command, if they are responsive to pain, or if they're unresponsive. That's the AVPU. So this is how you can monitor the level of consciousness. And then your peak flow measurements, which we should all be having. It's a very cheap tool. Is one that you can also use to see the progression of breathing. Because if your peak flow now, it says 320, maybe after 15 minutes it's saying 200, so you can see that it's progressively getting worse. So if peak flow meter is one thing that we can also have, which is shipped at the rural clinic. So transportation, I took these principles from the AMLS book. So basically, when the key points on transportation to a referral center, first of all, we have to assess the situation. Assessing the situation is when the patient comes in, your history taking, your bite sites, you see what the problem is, what has been done, clinical status of the patient, and also what needs to be done. So you assess the situation. Second, you control the situation. Well, how you control the situation is you identify the team roles, and then you assign the task. Okay, you'll be doing this, you'll be doing this, you'll be doing this. So you are controlling the situation. Then next, you have to do communication. Communication is very key, because you have to do it to the client, tell the client what you are doing and what needs to be done. Communicate to the relatives as well. Sometimes when you get so busy, we do not communicate to anyone. We just run around and do things. And the client doesn't even know what you're doing, or the relatives are not sure what you're doing. Sometimes we miss that. But it is important for us to communicate to our clients, to the key stakeholders at that moment in time. And also, then you have to communicate with the referral hospital. Tell them what case you are having, the clinical status of the patient, what you have already done, and what they will probably have to do when they get there. And then you evaluate the need for transfer and referral. Well, basically that one, obviously we know that the need is because it's a neurotoxic bite. We cannot keep the patient in the rural setup. We have to refer because the patient will need further management. And then package and prepare. When you package and prepare, you basically prepare yourself for any complications that can happen along the way. So take up any equipment that you might need for any resuscitation should you get there. This is how you prepare for what will happen along the way. Then transportation, we know. Physiological problems, we know that there are physiological problems that can happen because of transportation, because of harms. We heard Dr. Prez was talking about harms, they were jumping as they were transporting the patient. But what is important for our transportation is do not wait for an ambulance. We know in Swaziland we've got 977 for the rural clinics. 977, you will call them, they'll tell you they don't have petrol to come to where you are. Or if they're coming, maybe they're coming from Baban and you're in Lomahash. So you cannot wait for the ambulance. You'd rather be meeting them on the way. So whatever transport that you have, you need to just take that. If it's a van, please take that van and go wherever. Go and towards the referral hospital or center. So whatever is available, just do it. And most importantly, do the continuous communication with the clinic. So at our clinic, we are lucky. We do have Tia who drives like speed lightning, getting the patient. She's already calling us. She's already telling us, I'm bringing a neurotoxic bite. The patient is envenomated already. So we are all ready. We put up all the equipment that we have. We put up our antivenom. Sometimes when she gets there, she finds that the antivenom is ready. Okay, I'm almost done, thank you. So communication to the center that you are referring to is very key. Then let's talk about the limited resources and also the community involvement. For rural healthcare clinics, I've already covered this. Do have your basic resuscitation equipment for artificial ventilation. It is important that you have your basic monitoring tools. So if you work in a rural setup, please have your peak flow, please have your saturation, at least that one, have your BP curve, have all those things. And then do have your contingency plan for transport. if you need to transport a patient as quick as possible. Do have your basic BLS skills, and also importantly, I think something that we normally don't do in the country is adapt the protocols according to the resources that we have. It's no use having protocols that are going to be talking about intubation when you do not intubate, or protocols that be talking about oxygenation, and yet at the clinic level you do not have oxygen. So it is nice to have the protocol that is nationwide, but it is nice as a clinic to then sit down and say, okay, for our setup, this is what we do. At our clinic, we do sit down and do protocols that will specifically be okay for us as a clinic. And then community level, it's good to communicate, engage the local healthcare workers, social workers, community leaders, traditional healers. It is nice to do that because people will go to the traditional healers. But as a clinic, we need to involve them so that they be aware that what needs to be done if a neurotoxic bite or a snake bite of any case, it comes to them. So instead of them cutting the patient and putting Latin City, I think we've seen a picture from Dr. Christoph where it was black put by a traditional healer. They need to know that they cannot do anything for that patient. They need to refer the patient to the clinic. So if you have a buy-in for the traditional healers, you'll have less complications and you have more involvement of the community. They will play a first role in the first aid and also transporting the patient. Bomakelwane, if someone is needing transport, maybe there is a neighbor who has a car, they'll be able to assist. And yeah, and then so regular education to the community, prevention, first aid, management bites is also good. So lastly, recap, it is key for us as rural clinical setups to be aware of the neurotoxic signs and symptoms. I think it has been emphasized in the previous presentations that we have lost patients because we did not recognize the neurotoxic signs. So it is key for us to, because those are life-threatening. Maybe the cytotoxic diet, they can be a bit more, they cannot be so harsh on us, but neurotoxic bite, we must know the signs. And then you have your grasp of your respiratory support, because this is a gold standard for these patients. And then have your transportation plan to definite management, because at the end of the day, we want to discharge our patients. So in conclusions, we must focus on the rural specific aspects. If we work there, we should manage our neurotoxic bite. It is feasible to manage it even in a rural clinic. And then even with our limited resources, we can still save a life. So it's not a lost cause. And emphasis is on the timely management. You remember that patient that was lost because of 3 hours, but timely management is key, especially for us in the outskirts. First aid, transport, and knowledge and involvement of the community is very key for us. Thank you very much. That's the end of my presentation.
Thank you, Deb. Thank you, Bongi. Tendai? Sorry, I don't know what you look like. I'm like, where's this guy? Tendai, we went 5 minutes over for Bongi, so you can have another 5 minutes. But I'll watch your time. ICP anti-venom.
Good afternoon. Okay, so I will take you guys through ICP, which is the antivenom that we're currently using in Eswatini. So we're going to talk about background of snake bites. We'll talk about the ICP, also the kind of snake that it targets. We're going to talk about its role in the management of snake bites, its production, administration, as well as protocols regarding its administration. I think most of the things have been covered, like symptoms of snake bites, but we're just going to do a recap. We'll also discuss some adverse events that are associated with the use of this antivenom. We are also going to compare ICP and SAIMR, the antivenom that we previously used from South Africa. I think here we can all add, because I'm sure we are all using the current antivenom ICP. So snake bites remains a public health concern, and Southern Africa is a home to many venomous snakes, the likes of black mamba, puff adders, the cobras, and the impact of snake bites remains real. And because I think we've been seeing a lot of pictures there of patients with who have lost their limbs, those with nasty bites, as well as you can actually lose a patient through a snake bite. So not forgetting that we have also got vulnerable populations, those who are staying in the rural areas, as well as who are in agriculture, because they are working in, they are closer to the habitats of snakes. Imagine someone who's working in a sugarcane plantain, they are at risk of snake bites. So challenges are still there again regarding the management of snake bites, mostly limited access to healthcare facilities with advanced management, maybe airway support, and also antivenom itself. It's not every clinic or facility with antivenom. So I can't emphasize this more. We've been talking about that urgent case is very key in the outcome of our snakebite patients. So this is a picture of the antivenom that we're using, the ICP. So it can come in two forms. It can either be in liquid form or solid, which is that powder. So what is ICP? So basically it's a polyvalent antivenom, meaning designed to cater for a wide variety of snake bites. Okay, in our setting, we're talking about the mambas, puff adders, the cobras. So it's basically works through neutralizing the venom, right? Neutralizing the hemotoxins, the cytotoxins, and the neurotoxins. So this is just a family, the Echis species, we've got the viper. Okay, I will just skip this because we do have the snakes around, isn't it? Right. So I think here we've spoken about this, the effects of venom. There's hemotoxic, whereby it disrupts the way your blood clots, there's bleeding, like in the case of boomslang. Cytotoxic, you get to see cellular changes, right? The necrosis, blistering, ulcerations, and neurotoxic effects, whereby there's progressive swelling, there's ptosis, hypersalivation. Yeah, so, and also, venom can also cause some cardiac effects as well. For example, someone can present with arrhythmias. And also, it's also important for us to note that there are also other systemic effects we can expect for a venom. They can actually present with a fever, right? Or, just fatigue and all that. Yeah, I think Christo spoke about this slide when he was talking about how the antivenom is manufactured.
First, a snake's venom is collected and diluted to reduce its toxicity. This diluted venom is injected into a horse, making it very sick, but not to the point of death, to stimulate antibody production. After the horse recovers, it's injected again, repeating until it produces enough antibodies. Blood is then drawn from the horse's jugular vein, and these antibodies are separated in the lab to create the antivenom. So
this is a summary of what Christo spoke about. We extract the venom, it's inactivated, we inject in animals, then we extract it, we do separation of the antibodies, then we can have a final product. So the key steps we have to observe or you have to follow before you administer antivenom. So it's very key to assess your patient, right? You have to assess for signs and symptoms of inflammation. We're talking about your ptosis, how's the swelling, and so forth. So it's very important for you to also check your vitals, your BPs, right? As you have said, someone can present in shock. So it's very important for you to check how is the BP, how is the pulse, and those determination. So it depends again on the level of inflammation. I think Crystal mentioned that you can, assessment is key, right? You've given antivenom, but you can see maybe after a day, they still have signs. There's maybe the fasciculations, there's still some signs concerning of inflammation. You can still add. So preparation, we have to just do it in a sterile procedure. In terms of route of administration, you can give either IV or IM, but IV being the preferred route because of its fast absorption. And we have to monitor your patient for signs. When you are giving the antivenom, you have to check for adverse reactions. So you can have to expose the patient, check for allergic reactions. They are on a monitor, right? You are trying to check if there is drop in the saturations, your BPs, your pulse, right? It's very important that when you're giving the antivenom. Then supportive care is given as needed. Like if they're saturating, you have to give oxygen support. They need fluids, right? If they develop hives, maybe you can also give an antihistamine, your promethazine, hydrocort. It also helps. So post-administration of antivenom, it's also key that you monitor a patient. It's not just about giving the antivenom. You've given an antivenom, but they can still have delayed reactions. So you can schedule maybe every 30 minutes, you monitor a patient, you do symptom check, right? You check, is there any process? How is the swelling? Is it progressive? Is it getting worse? Is it in other signs of inflammation? Okay, so regarding administration of this antivenom, is very easy to administer. What you need is you need an IV access, you need adrenaline, you need antivenom, sterile syringe, needle, gloves, cardiac monitor. It's very key for you to be monitoring your vitals. You also need a syringe pump if it's available because you have to give a slow push. Ideally, you can give it over 5 minutes, the ICP, whilst you're observing your any sense of adverse reaction. So I'm saying it's very key for you to check the adverse reactions. We should also have a ventilator and intubating kit on standby should there be need of maybe if it's a neurotoxic bite. Okay, clinical presentation, I think we discussed about this already. It depends on the snake that is bitten the patient. You can have neurotoxics, they have neurotoxic symptoms, the ptosis, hypersalivation, respiratory, like they have difficulty in breathing or an elevated RR. On the wound, they can have bleeding, right? They can be discoloration, bleeding, swelling, depending with the kind of snake that is bitten the patient. So this graph is data from TLC from 2020 to 2024. I think one thing to note about this graph is that it's not every patient who needs antivenom. Right, as you can see, in 2024, we had a total of 420 snake bites and only 42 patients were given antivenom. Okay, so it's also key. It's also highlight the importance of assessing your patient. Right. Thank you. It's also important for you. It highlights the importance of assessing a patient, right, to see if they really need antivenom. Because sometimes we may end up giving antivenom to patients who don't actually need the antivenom. Okay. So this is a patient we treated last year. This patient presented unconscious with a history of snake bite. So we intubated the patient. We gave vials of antivenom. On day 3, there was no response. Then on the 4th day, he started twitching only the hands. Around day 5, he was still not communicating, but he could respond to verbal commands. Then around day 7, he was not communicating, but he could respond. We say, raise your hand, he would do that. Then after 8-9 days, he was now up. So he was also a survivor from we received SCP. So here we're going to just compare ICP and SAIMR antivenom. So with the SAIMR, we noted that 6 in 10 patients had adverse reactions, whilst with the ICP we haven't noted any much of reactions. So the common reactions with the previous antivenom we're using, we had pruritic rash, the fevers, tachypnea, and some would actually saturate. And with ICP, we've only noted HIVs, which is last year, I think we had only 3 patients, 2 pediatrics that allergic rash, one had one was an adult with rashes. In terms of severe reactions, 10% of our patients had anaphylactic reactions using the SAIMR, whilst we have not seen any adverse reactions with the ICP. Then for pediatrics, most of our pediatrics, I would say nearly 90% they had adverse reactions using the SAIMR, whilst using the ICP, we have not noted any severe reactions in pediatrics. So in conclusion, we can say that the ICP has significantly better safety profile. Yeah, okay, it's better in terms of safety, and than they both have they achieve the same function, which is the same Snakebite, but it is a better safety profile. Thank you.
Cool, thank you, Tendai. All right, ladies and gentlemen, no, there's no time. Prof. Tim Hardcastle is waiting in the gallery, online, waiting to do his presentation. So just give us literally a minute or two just to get the tech stuff ready and get Professor Hardcastle up on the screen. Okay. I think, yeah, let's do that. Sorry, Bongi.
Yes, my question is to the Law Commission team in terms of anaphylactic shock when it comes to anaphylactic reactions to the antivenoms. So what do you do if you give the first vial and they develop the anaphylactic reaction? For us at the clinic, it's easier. They develop the anaphylactic reaction and we stabilize and we send to you guys. But I'm just thinking, sometimes we've been sent with antivenom, but for you guys, because now you can't send to anyone, what do you do?
All right, so we were employing different strategies because for the SAMIR, that one, we were experiencing quite a lot of it. So most of the times after the first or second vial, you do that, but you want to give 4 or something like that. Our technique of administering was the one that would then change, would still have to try again, because I mean the venom is going to do it. So you would have to write out the anaphylaxis, treat it, and make sure the patient is stable. Then after you establish stability of the patient, 2 hours after that, you are ready with everything again, and you try, but this time we would dilute it further and administer it over a longer period of time. So our standard was initially IV push over 10 minutes, right? So now we see an anaphylactic reaction, we would then go maybe in a bag of saline over 2 hours, running over 2 hours or over 3 hours, something like that. That's how we would try.